Welcome back to ArkanSense, where we try to take an unbiased look into issues affecting the natural state. And today, we're going to talk about the Arkansas Works program. There's so much information to know if you really want to understand the program that it had to be covered in 2 episodes. This is part 1, which covers everything before the work requirement was added, including what Medicaid is, how it started, how it was implemented in Arkansas, and how Arkansas Works evolved from part of Obamacare. Part 2, meanwhile, will cover what the work requirement is, how it was implemented, whether it's achieving its goals, and what's likely to happen to it in the near future. We've got a lot of ground to cover, so if you want to skip directly to one section of this video, or even go directly to part 2, you can click on one of the links in the description below. So let's start, as always, with some history for context. Back in the early 1900s, better medical technology led to a rapid increase both in population and in how long people were living. But the rise of the nuclear family ideal, living with just close relatives rather than many members of an extended family, also meant people had fewer sources of financial help when they hit hard economic times or retired. In the 1930s, the Great Depression struck, and President Franklin Roosevelt put together a package of laws called the New Deal. One of its goals was to provide relief for impoverished Americans who couldn't find any work, and it did that in part by creating Social Security, a program that provides elderly Americans monthly payments to help with their costs of living. Social Security passed in 1936, but both President Roosevelt and his successor, President Truman, wanted to expand the program to cover medical costs for the disabled, sick, and poor. Around this time, many countries were transitioning to some form of tax-funded healthcare, but in America, we never made that leap. Part of the reason is because during the economic boom of World War II, President Roosevelt had frozen wages as a way to prevent inflation. In turn, businesses who could no longer offer higher pay tried to attract employees by offering benefits packages, including healthcare plans, so employer-sponsored healthcare became the norm. And as the Cold War took off, opponents were quick to associate any kind of government assistance programs with communism, which kept Truman's plan from progressing through Congress. But by the mid-60s, the Cold War was transitioning from active fears about nuclear war to the space race and proxy conflicts. President Kennedy laid the groundwork for additional medical assistance programs for the poor and elderly. And 2 years after his assassination, President Johnson signed into law the Social Security Amendments of 1965. Under one part of this amendment, the government created a program where federal funds would match contributions by states to pay for the health care of impoverished people who were also elderly, pregnant, raising children, or have a chronic medical condition. It also covers the disabled regardless of their income. So if you fell into one of these groups and had, say, a $200 hospital bill, the federal government would pay for at least $100 of it, more if you lived in a particularly impoverished area, and your state would then pay the rest. And the name of this program is Medicaid. States didn't have to participate in Medicaid, but many, including Arkansas, already had welfare programs in place, and replacing them with similar programs partially funded by the federal government might be less expensive. When a state began participating in Medicaid, the state would craft their own program providing coverage to all the groups required by the federal government. States could then decide if they wanted to expand coverage outside of those minimum requirements. Some chose to cover more conditions or even to include everyone under a certain income level, but others kept the bare minimum. In the most strict states, healthy adults with no children could not apply for Medicaid no matter how poor they might be. Arkansas joined in 1970 and as one of the poorest states received one of the highest rates of Medicaid repayment. For each bill, the federal government paid about 75%, leaving Arkansas to pay just a quarter. Through the 70s and 80s, Arkansas made mostly minor tweaks to its version of Medicaid. But then in 1996, Arkansas ran a statewide study on the program with the intent of finding ways to reduce spending. Instead, one of the key findings was a high population of parents who made just enough that they didn't qualify for Medicaid, but so little that they couldn't afford private insurance for their children. Then Governor Huckabee proposed that the state expand its Medicaid program to cover children of families who made above the Medicaid maximum but less than 200% of the federal poverty level. The federal government approved the plan, and Governor Huckabee signed into law the new program called ArKids. The very next year, the federal government instituted the State Children's Health Insurance Program, or S-CHIP, which was largely the same as ArKids, but here in Arkansas the decision was made to keep the old program name, in part because polling suggested some families might be unwilling to stick with the program if they thought it was part of Medicaid. This illustrates the complex relationship that Arkansans often have with federal programs. Despite being one of the states that takes the most advantage of them, many Arkansans have unfavorable views of programs if you call them by their federal name, but view the same program favorably if you call it by its Arkansas-specific name. Back on the national front, Medicaid had been slowly expanded over time to provide more coverage to the same or similar groups as the base program. But the largest attempt to expand it was the Patient Protection and Affordable Care Act, more commonly known as the ACA, or Obamacare. The ACA expanded the Medicaid program in two big ways. First, it extended Medicaid coverage to everyone whose income was less than 138% of the federal poverty level, even people who were completely healthy. This part of the ACA is called Medicaid expansion. Second, people making more than 138% but less than 400% of the federal poverty level would be eligible for a combination of direct payments and tax cuts to offset part of their healthcare premiums. These subsidies could be used with the new insurance marketplace, which was the collection of private insurance plans that meet ACA coverage standards and accept payment from these subsidies. That's why they're called marketplace subsidies. Before the ACA, the income range each state had to cover with its Medicaid program was based on that state's poverty and unemployment level. But Medicaid expansion made that level the same for every state based on the national poverty level. Without this expansion, there would have been a coverage gap in some states, a group of people who made too much to be covered by that state's Medicaid, but too little to qualify for the marketplace subsidies. But with both parts working together, every American under 400% of the federal poverty line would either be covered by Medicaid or eligible for insurance marketplace subsidies. While avoiding a coverage gap was one reason for the expansion, there were many others too. The more people who are insured, even if it's through Medicaid, the lower healthcare costs are for everyone. That's because there are fewer unpaid hospital bills, more preventative checkups, and a larger pool of funds from which to pay benefits. And eliminating all the exemptions also eliminated some government red tape. No longer would anyone have to prove if they were pregnant or a caretaker or injured. So long as your income was below the cutoff, you were covered. Increasing the Medicaid cutoff and eliminating all exemptions meant that a lot of new people would be eligible for Medicaid, adding a huge cost to the states. To try and offset this, the federal government would cover 100% of the increased costs for the first few years and then slowly scale back to 90%. So states would only be responsible for what they always had been, plus a maximum of 10% of the new costs. The ACA passed in 2010, and once it did, states had two options: expand their Medicaid coverage or get off Medicaid entirely. Almost immediately, a number of court cases began challenging the ACA's legality in whole or part. Most of them were dismissed in lower courts, but a few made it to the Supreme Court, and one was a challenge to the Medicaid expansion. The argument against it went like this: while the government definitely has the right to set and change the terms for its state grant programs, it does not have the right to force a state to participate in one of those programs. At the time the ACA was passed, every state was voluntarily participating in Medicaid, and in some states, the money they were getting accounted for more than 10% of that state's entire budget. The side opposed to the expansion said that losing such a huge grant wasn't an actual choice for many states, and so the new rules amounted to being forced to buy into the new plan. And the Supreme Court agreed with them. The court said that by not only changing the payment levels, but also extending coverage to so many new people, the Medicaid expansion wasn't truly a change to Medicaid, but closer to a new program entirely, and threatening to take away the old program to force states to join the new one is unconstitutional. So, moving forward, the Medicaid expansion would be optional. Each state could choose whether it wanted to stick to the old program or expand. But Arkansas decided to try and forge a third way, to have its Medicaid and eat it too. After the Supreme Court decision, most southern states rejected expansion entirely, but Arkansas, in a compromise between the Democratic governor and the largely Republican legislature, decided to try and apply for a waiver to create their own unique version of Medicaid expansion. Section 1115 of the Social Security Act allows states flexibility in their specific versions of Medicaid. States submit a request for a waiver detailing how the state will provide the same kind of coverage the base program does, just in a different way. The federal government then denies or approves that waiver. Before the ACA, some states had received 1115 waivers to expand their coverage and put those new recipients on private insurance plans repaid through Medicaid. Arkansas took that idea and decided to try doing it with everyone covered under Medicaid expansion. So Arkansans who qualified for Medicaid expansion would be covered by one of the private insurance plans from the healthcare marketplace. Those insurance companies would then be repaid through the expansion grant, 90% from the federal government, and from Arkansas, just 10%. This approach to using Medicaid funds to pay for private insurance is often called premium assistance, or the private option. But why do this when it seems potentially more complicated? The state gave three main reasons in its request for a waiver. First, Arkansas claimed that using the private option would reduce costs compared to a plan run by the state. Second, state-run plans tend to pay doctors less for services than private policies, which is why some doctors choose not to see people on non-private option Medicaid. Putting most people on private plans could mean better paid doctors and fewer people turned away from clinics. Finally, the state claimed that keeping people on private plans would reduce the effects of churning, which is when someone's income is teetering right on the edge of Medicaid's upper limit, so they keep having to switch back and forth between a state plan and a private one, potentially with time during the change when they aren't covered at all. Under the private option, you could keep the same plan and only change whether it's paid for with Medicaid or subsidies. The arguments were compelling enough that in September of 2013, Arkansas became the first state issued a waiver for Medicaid expansion and began implementing it the next year. Before Medicaid expansion, Arkansas had the lowest income cutoff for Medicaid eligibility in the country, so the number of people who were suddenly covered starting in January of 2014, when that cutoff went up to the nationwide level, was massive. The uninsured rate in the state for non-elderly adults dropped from 27.5% to 15.6% in just the first year, and nearly 4 in 10 of the new Medicaid enrollees had health insurance for the first time in their life, and that huge enrollment increase drove down the average price of marketplace premiums. But 2014 wasn't just the first year for the implementation of Arkansas's Medicaid expansion, it was also a midterm election year, and the ACA was one of the major issues on voters' minds. Polling indicated that people who were against it were twice as likely to show up at the polls for a candidate running on that issue. Candidates in Arkansas primaries campaigned on die-hard, fight-to-the-death opposition to the private option, as one reporter put it, and told voters the only way to get rid of it was to elect Republicans, and that's exactly what happened by huge margins. In Arkansas, of the 7 state executives up for election, Republicans, who had previously only held 2 positions, won all 7, and that included the governorship won by Asa Hutchinson, who had specifically framed both President Obama and the ACA as opponents in his campaign advertisements, like this one.
Our next governor will have to stand up to a liberal president and fight for Arkansas against federal overreach. President Obama has already raised millions for groups trying to defeat me. Well, there's a reason I'm not his choice. I oppose Obamacare.
Some people expected the newly elected governor to pull the state out of Medicaid expansion, but Governor Hutchinson understood the political risk of eliminating the program and turning down the federal money that came with it. In a policy speech about the program, he said he was torn. On the one hand, he viewed Medicaid expansion as government overreach, but he also loved that Arkansas had taken the initiative to develop its own experiment, so he offered a compromise. He asked the state legislature to keep the existing programs going for 2 more years. In turn, during those 2 years, an independent task force would try to find an alternative model to the private option, as well as other money-saving changes that could be made. Governor Hutchinson also took some time during that speech to talk about his view of social programs, a view that would end up shaping the coming changes.
I want our social programs in Arkansas to be an incentive for people to work versus an incentive for people not to work. And Arkansans want to work. And when they work, they should get ahead. And when they work real hard, they should be able to climb up the economic ladder. And I believe the vast majority of Arkansans want to work. Nobody who is able to work wants to stay on government health care. They want a job. And while it's encouraging to see so many folks now insured who did not have health insurance before, I'd like to see us reduce that number, and we can reduce that number as we move people to work and they move up the economic ladder.
Just a few days after that speech, lawmakers passed the Medicaid expansion extension and created the task force they'd been asked for. Meanwhile, the state's positive trends continued. By mid-2015, the uninsured rate was down to 9%. The number of uninsured children dropped similarly, and the growth rate for state Medicaid spending was about half of the national average. In October of 2015, the task force released their initial report, and based on those results, Governor Hutchinson proposed a rework of Arkansas Medicaid expansion, with a few key changes, as well as a brand new name, Arkansas Works. He then went to the federal government with those proposed changes in order to negotiate a new 1115 waiver with the Obama administration. Under the new waiver, anyone on Arkansas Works but above the federal poverty line would pay 2% of their premiums each month, between $20 and $28 at the time. Also, the Department of Human Services would expand their workforce training and outreach programs, and anyone on Arkansas Works would automatically receive referrals to those programs. Additionally, there were some other small cleanups and changes to try and save money in a number of different different ways. But what wasn't included was also notable: a work requirement. That's because when Governor Hutchinson went to negotiate for the new 1115 waiver, his request to include one was specifically denied. Meanwhile, the number of people enrolled in or eligible for the state's Medicaid program, that's base Medicaid plus Arkansas Works, continued to increase, reaching above 300,000. Though the Medicaid task force had predicted Arkansas Works would save the state $438 million over the next 5 years, some conservative Arkansas lawmakers saw the enrollment milestone as a sign the program's cost could balloon out of control and believed there needed to be some way to reduce the number of people covered. And while Governor Hutchinson's attempt to do so with work requirements had initially been rejected, the possibility opened up again after an unexpected turn of events in November. On November 8, 2016, Donald Trump was elected president, and just 3 days after the election, Governor Hutchinson said he planned to ask the new administration for an expanded 1115 waiver, which would include things the Obama administration had denied, like work requirements. It took the Trump administration a while to respond to the request, in part because much of their first year was spent trying to repeal Obamacare. If the ACA was repealed entirely or replaced with something that changed Medicaid expansion, Arkansas Works would change too. But ultimately, the attempt to repeal the ACA failed, and the Trump administration began a process of undermining Obamacare by weakening a number of its programs, including Medicaid expansion. The Trump administration believed, quote, the expansion of Medicaid through the Affordable Care Act to non-disabled working-age adults without dependent children was a clear departure from the core historical mission of the program, unquote. As such, the expansion grants were to be seen as an earned reward, not an expected handout, and states would be allowed to impose more strict restrictions through their 1115 waivers. So in March 2018, the Trump administration approved Governor Hutchinson's work requirement waiver, and implementation began in June. And that's it! We're done with part 1. Hopefully now you understand the basics of Medicaid, the Medicaid expansion, and the Arkansas-specific version of that program. And if you watch part 2, you'll hear about the work requirements, how they were rolled out, whether or not they did their job, and what will likely happen to them in the near future. There's a link to that video in the description below. Thanks so much for watching, and also a special thanks to Benjamin Hardy for his help with this video. If you enjoyed this and want to see more videos like it, please support ArkanSense on Patreon. Patreon is the easiest way to support content makers in a way that works for your budget. You decide how much you want to give each month and can change that amount at any time. Bigger donations get bigger perks, and speaking of perks, a special shout out to Zach Green, whose monthly donation of $50 let him pick the topic for this video. Thanks also to our other patrons, Don Hughes, Zach Clark, Jason Sanders, and Kelsey Robbins. If you want to become a patron, there's a link in the description below. Thanks again, and see you next time for more ArkanSense.